e-learning program EPL-03 organized by SCM-PCR. Main objective of SCM-PCR is to organize awareness, prevention and screening program for cancer disease and to provide adequate training to all personnel associated with cancer treatment. SCM-PCR is very active and dynamic group for the purpose of teaching, training and young medical physicists across the South Asia. SCM-PCR will establish the clinical residency program for medical physicists in future. Today topic of lecture is the treatment procedure, image acquisition, patient positioning and immobilization, which is going to deliver Diploma Engineer Renate Walter, Medical Physicist and Radiation Protection Commissioner at University Hospital, Augsburg, Germany. She was the speaker in the last class also. Now I invite to our speaker, Diploma Engineer Renate Walter, to deliver her talk. During the lecture, if you have any suggestions and questions, please type in chat box. And I also request to all participants, please mute your microphones and turn off your cameras during the lecture. Now you can start your presentation, ma'am. The floor is yours. Please start.
Thank you very much. And good afternoon to everybody. I say hello from a very cold area in the world. We have had minus 15 degrees Celsius outside today. I think it's now around minus 10 degrees, but it's sunny. However, today we want to talk about treatment procedure, image acquisition, patient positioning, and immobilization. First, I want to thank you to the organizers for inviting me to contribute. And as I already shown last time, the University Hospital Augsburg is using brachytherapy equipment from Elekta. Okay, so the class today will be treatment procedure, and my theme is going on these 3 points, mainly image acquisition, patient positioning, and immobilization. So a whole treatment procedure is starting with the medical examinations and the explanation by the physician to the patient what's going on. So, and for the next appointment, it starts with preparing of the patient for the procedure, then the patient positioning, immobilization, applicator placement, and needle insertion, catheter implantation. So after this, you can go to the image acquisition planning, and after finishing the plan will be loaded, or the treatment file will be loaded. You have to check the plan, check the connection, treat the patient, and then disconnect the patient and release from its position and immobilization, and it should be care for the in ongoing care. So, as you can see from the title, from that what was arranged or announced, my theme today is more somewhere here in between. I won't not talk about all of these points of the treatment procedure, but what is important to know that you have to keep your immobilization from here to here. So when you have positioned your patient and make some with some help prevent him from moving, then you start with your applicator placement and so on. Then you go to image acquisition and planning, load and check plan, treat the patient, and until you come in again for disconnected, the patient must be immobilized or stay calm. So the medical explanation is usually by the medical doctor, and then comes the preparing of patient procedure. So this is done by the RTT or RT, and they are in our hospital already involved. And these are 2 very important steps in the beginning, because this personnel who is seeing the patient first, they know how compliant the patient will be, or if there are any restrictions. So it can happen that the patient has got some problems for keeping in certain positions because he has got pain from the disease which should be treated now, and other patients have some problems. They are of reduced general conditions, or they have some breathing problems and so on. But we had we treated in our hospital already people with dementia or other mentality retarded situations. So we had been already in the situation that we seem to need some fixations. And when you need fixations, you must clear it from the legal part. So here in Germany, you cannot just go in and use some fixation, prevent the patient to move his hands and his feet. Yeah. So this is must be clear with people who are responsible for the person. So let's go to positioning immobilization. So the first, what I'm thinking of is how my treatment table is looking, or what do I have where I can place my my patient on. So usually when you come into a hospital and there is a brachytherapy unit, there's always somehow a treatment table. And so usually the companies who sell you the machine, the afterloading machine, they usually provide some good ideas for treatment tables. But sometimes, especially for skin treatments, the patients do not need to lay down on a flat couch, but can be seated in a special chair too. But what is very important, or sometimes even overseen, the patient in an upright position, was seated somehow, should be secure to prevent to fall out of seat. So I learned from a colleague, he told me that this happened in his hospital, that somebody had a collapse of his blood pressure system, and so he fell. He has fallen out of the chair, and so the machine has fallen onto the transfer tubes, and so it was a little bit a difficult situation. What is very important, please keep an eye on the limits for patient weight of your table. So our table has not that big limit, so it is around 130 kilograms is the maximum patient load. You see here our table. We can add some leg rest, so that we can place the patient in lithotomy position, and we can add an elongation here, take down the legs, place the legs here, and remove the leg rest, and then we can move the patient to the CT scanner and place and to do our CT. We have here, it's very nice, fitted to the CT, so it's rolled somehow over the CT table, and by rising up the CT table, we can lift up the table or the tabletop of our brachy table, and it's carried by the tabletop of the CT scanner. So we pull back then I think I prepared it here. So this is lifted up, we pull back the latch here, and then it can move free into the gantry. You see here the leg rest is mounted here because usually we now start right here in the CT room on the table. Here is enough space between table and gantry for our medical doctor to work, and so that he can work from this side, and the patient is lying here. And when he is finished with his work, the legs are taken down and we do the CT scan. So sorry. Okay, and so bringing in that it's needs some space because we have a lot of personnel there, and except for vaginal cuff treatment, in that case we start in our brachy room and bring the patient from the brachy room to the CT scanner and back. For all insertion which are needing anesthesia, we have got the anesthesia team with us in the CT room, and so there's a lot of people working there. So this is how it looks like then when it's going through. Good. So now we go on. We are well prepared for gynae. So you start and place you have your patient the right placement, and start to insert the applicators. And what is important, how to keep the applicators where they are. There are some options. The options we prefer now is to use plaster stripes to keep it where it is. You can see it here, and it is coming from here and one from here, and it works pretty fine. We know this because sometimes we need to add additional needles later because the medical doctor found out it was not enough needles there. So we knew that it's well fitting and keeping the applicator in position. And yeah, so it can look like that when you have some more needles. And before we are doing the imaging, we connect already the needles. It is easier to connect the needles to the transfer tubes when the legs are placed in the leg rest, and then we take down the legs, and later I take a look on that for checking. Okay. So to prepare for imaging and treatment by gynae applicators, you must keep them in place. You have seen how we do this. In some hospitals, maybe in your own hospital or department, it is Martin's arm retractor system installed at the table to keep it in place, or an applicator clamp. This Martin's retractor system doesn't go as well through, or might be a little bit disturbing when you are working with CT scanning. But when you are using it in a brachy room and you decide do the treatment in in this feet up position, it works quite well to keep the applicator in position. I know that some vendors for brachy equipment, they provide an applicator clamp, which is even possible with this clamp to go through the CT scanner if you have an option to mount it in the right position on the table. We use usually muslin bandage or plaster stripes, and yeah, so connect transfer tubes and take legs down from the leg rest before scanning. Okay, so the next, what I would like to take a look on is how to go on with preparing superficial molds and slabs. I do not know how many of you have already seen skin treatments in brachy just by using these superficial molds, and or maybe some of you use these Valencia applicators. So from Elekta, we get that Freiburg flip material. These are, it's a big mat, I would say, made of all these balls. You have seen that, yeah, it looks like that, and you can cut it down to have a smaller size, and then you can put so you can pull through a flexible catheter through these hole in this, and you secure it with these buttons. But sometimes it is better to have something more smooth, like for the nasal cavity. So we use this material. It is something which you use to provide too much noise for your ear. You can take it and pull a flexible catheter through. It looked like that. We removed here the button at the end of the catheter. You have to be very careful that you do not pull it through, and then you can place it into the nasal cavity. So this is a flap we prepared to be placed onto the nose and adjacent area of cheeks. You see that we removed some buttons from here. So here we have the buttons here and there, but here we are close to that point, the root of the nose. So it's more comfortable not to have these hard buttons there. And on the other hand side, if you have the hard button there, your first dwell position is here, but it is better for the patient comfort to have that placed to remove that. Okay. What we else tried out, but this material we had here for usage was not the best material in our opinion. We made a mold out of aquaplast. This is thermoplastic material. I think the most departments have some water bath supply that you have there 60 to 70 degrees Celsius. And for this masking system, when you want to treat in EBRT the head or for head and neck patients to keep them in position for the linac, and you can use it to for this aquaplast material. It is a special material which is designed for radiation therapy. You heat it up and then you can form it. The idea is to have a bolus material for 6 MOV. So sometimes when you need to treat with the linac, something what is very close to the surface, it's sometimes helpful to have some bolus material onto the skin. So we use that and place the catheters in this material. You see it here, and but it is we want to keep it together. That is not that easy. So it was nicely by our RTT covered by plaster stripes to keep it together, and that the catheters here do not move and stay in position. So it is one option. What is very good with this material that you can first or you can prepare this mold without making images. Then you can check this if these catheters are placed properly. Otherwise, you can make another appointment with your patient. And when you are happy with your mold, you can do the CT scan. And when you do the mold for an area where you do not need to, where no organs at risk are nearby, in this case, we have the eyes nearby. You can see here is the area of the eye. But if you do not have organs at risk in the nearby, you can try to, or you can calculate your plan, maybe even without patient. So if you have a part of a leg or what else. So, yeah, and indeed we treated legs too. And so the skin area to be treated is delineated by the medical doctor. And our IT is placed the flap and fitted it so that it is close to the skin. You need some experience to make it happen, but flap and skin are come together really. So our RTTs, they are using rolled muslin bandage and placing up here, and then we have some extra pressure on some places to get the best fit. So after finishing this placement of the flap and fixation with muslin bandage and plaster stripes, we do the imaging. So, but what you need to know is this must be done every day for every fraction. And so it is a lot of work connected with it. We thought in the past maybe it is faster and much easier when we use some masking material. So we tried out this too and placed or fixed just with plasters our little mold here. In this case, it is only one pearl of this elastic material. And we just placed it, so the patient had to lay down for this. And he was connected to this masking system. So the problem is that you need an additional holding the or masking system which you can place on your brachy treatment couch. This is not always available and possible to add on. Here we have got another example where we try to place a flap most optimum on this on the patient. It was on his neck, on the back side, and it was a very, very sensitive area. So we formed by this masking material collar, and there was and we sewed on it this Freiburg flap material. And what is very important when you fix it with some sewing material from surgery, that you take this way for fixing your flap onto the carrying material, and not in that way, because you have to pull strongly, and it would not be good for the source to go through this when you have too much pull on when this material is pulling through that catheter. So here you see a part of the face, since we have to be very careful when we show patients. Here comes the eye, here is the nose, and here follows the ear in that direction. So it is, our RTTs told me it is faster and easier to just to add or to fix it by plaster material onto the skin. It will keep therefore the treatment time and stay safely there. What else you can see here is something like a obliquely spot. And now we have got these Oncentra Brachy TPS, which has a graphic card, and we have a 3D volume rendering. So we see very nice where we are with our applicators and our flaps or whatever. So in the past, when we used Plato for planning, we had not this nice 3D image of the CT data set. And so it was sometimes very difficult to be sure on which direction I'm really working. So you should be aware if it is very stressing and the RTT at the CT scanner gives in the wrong direction of your patient, how the scan is going. And so imagine your patient is will be scanned feet first, like it's happening in for gynae, and the RTT is giving in head first. So when you have needles, it might happen that you believe you had one needle on the right-hand side, and indeed it is on the left-hand side. So to prevent, with a 3D imaging, you can see it very well, but it is very helpful if you have one point you place there and you know, okay, where I see this point, I know where is right or left, whatever. So we always place this point on the right patient side, so it got a little name. This is my the Mrs. Walter right-hand side point. Okay, so when flaps or molds are properly fitted and fixed, you can place the patient. You should place the patient comfortable on the CT table, and if possible, the patient should not lie on the flap. So we have sometimes the point that patients have some lesions on the back, so they should try to lie in a side position or on the front position. So for some parts of the body, it is possible that you, for scanning, keep something like the arm close to or the hand close to the body, and for treatment you can put them more away from the body. So let's see how we prepare a patient for needle implantation. Usually these patients are under anesthesia and completely relaxed. So for one fraction of steam needles, no movement is to be expected. And but we have also patients with flexible catheters. They receive a multi-fractional treatment, like for some boosts in head and neck treatment, like tongue ground, yeah? And or something like lymph nodes in shoulder area or on chest wall, whatever, and or recidivum of chest walls. They are so. Patient positioning for treatment is not always the same as for implanting under anesthesia. So especially, so I think for tongue ground, it's not that big different. But when you do chest wall treatments and on the side of on the body side, under the close to the arms, so or the shoulder area, so when during the implantation, the patient is positioned with arms upwards, and later for treatment, the arm is to the side or downwards, depending on the pain the patient is suffering. And so there is a stretching and changing in your implant. So you have to keep that in mind and maybe suggest to do the CT scan for planning when the patient is out of anesthesia. So, and this is a table prepared for this. You see a little hammer. So we do some treatments with for bone metastasis. In that case, you need some a hammer to get through and very stable needles too. But for other materials, it's a little bit easier. So that's how it could look like. And very important is that you have a documentation where your needles are. This nice case for these procedures, our patients are always completely relaxed. It's very easy, but the anesthesia team has to take care that the patient is in deep anesthesia for that. You see here numbers down here. I hope you can see it. Something like this. Here is number 1. You find number 1 here. Number 8. You find number 8 here. So we take photos for this, for having documented how our treatment was, and connect it to the machine. You see here, very important is that there is no weight or pulling what is exerted onto the needles, that there is a pull down to of the needles. So we take a stative for medical stative, and fix it, fix the transfer tube that they go up, and there's no weight by the transfer tube working in that direction. Yeah, sometimes it's not very easy to see where the head of the patient is. So we have this little nice drawing from our doctor to see this. And you see here a very nice, clear numbering, and that this numbering is conform with that what we added here. So our transfer tubes are connected correctly. So, and here's another case how we managed to connect it from the machine, to connect the machine with the needles. And usually we have no problems to keep it in place for the whole procedure. So this is another example. We have here interstitial catheters combined with the flap. The interesting point is because of this big tumor, the patients got already this suggestion for an amputation, so that somewhere the arm should be cut off. But the patient said, no, never ever, and came to our department. And it was a very big tumor in that place. So our medical doctor inserted needle and flexible catheters. You see, this is our OncoSmart system here, or Elekta provided an OncoSmart system. And, and he added a flap on site to have here really high dose onto the skin, because this is all skin. It's by tumor, from the tumor. What is a big could be a problem is how to manage an interstitial plan with movable flap. So these channels don't move, but these channels can be dislocated. So you have to think about that, how you can minimize the risk of creating unseen hotspots of dose due to flap displacement between the fractions. So this was treated in a fractionated scheme. And we decided to give all dwell positions in the flap the same dwell time. And I know that there is an option available since a couple of years on Syndrome Brachy, where you can log the weighting factors for the flap or for certain channels. So you can log it for all the channels in the flap, so that you can create a more smooth and harmonized dose distribution for the flap, and then work out, maybe better work out the dose distribution for the interstitial catheters. But we bought our license more than 10 years ago, where this was not available. When you try out to do this or want to do this, you have to check what your planning system which options your planning system gives you. So, and this is how we manage it for treatment. You see here connected the OncoSmart catheters. This is very helpful that we only during treatment or for treatment, the patient has got these catheter, which are longer here in the so this is this connection system. So after when the fraction is done, flap and these catheters are removed, so only the buttons of the inserted catheter part stay there. So this is how it looks later. And here you can see how it looks without that inserted catheter. So we have another example of hand and how you can place it there. We use this, it is a cushion meant for the legs, but we place it there that the old lady can rest her hand there. We covered it a little bit, that there is not a contact between the healthy skin to the catheters here. And we take care that the curvature of our transfer tube is not too small. Okay. So, yeah. So preparing a patient for needle implantation. So, yeah, as I already said, usually patients under anesthesia. And so for one fraction with steel needles, no movement is to be expected. In this case, we do not connect the needles to transfer tubes prior imaging. Yeah. And so, and it's very important that patients with chest wall implants won't be treated in the same position as implanted. So it's you need some experience to find the optimal position prior scanning, and the patient is still under anesthesia when you do this scanning. So you need some experience to find the best positioning for your patient. So now I want to go to the imaging. Well, so the most of you, or I think so, know that imaging in gynae is very traditional, just to do by an X-ray machine, by a by this X-ray machine, where you can change the direction from 0 to 90 degrees. And we do not have this in our department. So I try to mimic this X-ray images by DRRs from the CT scan. So yeah, what I want to say is usually you see on this X-ray image only the bony structure. So you have no idea where bladder and rectum is. So you can think, okay, here you see the rest of your, or you see a shadow or something of your applicator. Here you see the dosimeter for the rectum. So, and then you can guess somewhere here in between there must be the rectum wall. And but where the bladder is, maybe if you have a catheter with a very good with an X-ray opaque end up here, you can see it better, but you do not know where your bladder wall will be. Maybe with some contrast agent it will be better. Okay, so what you see here is, since it is derived from a CT, in my CT there is of course a bladder and a rectum contoured. You see it here. So, and usually you know it from the planning, you can just do the plan without images there, and you just define your catheter and the points where you want to have the dose, in which this usually it is defined on the distance for the vaginal cuff in the middle of your the middle dwell position with the radius of your applicator plus 5 millimeters tissue depth, and then you can mark the point if you the points of your rectum dosimeter or rectum probes. So okay, so when I started in brachytherapy, I started with these images above here, with this image quality, just with X-ray images, and you have no idea how the real rectum looks like, and you can get out only the information of your rectum probe. So it is possible by these two images to define the places of the 5 probes in relation to the to your 12 positions. Good. So when you have the opportunity to go on a CT scanner, you know a little bit more about your patient, because you can see where is the real bladder and where is the rectum wall. Yeah, but I think for vaginal cuff, 3D planning and the DVH is helpful to have. And especially if you have to treat recurrences, it's very good. But there are many protocols for vaginal cuff treatment which do not change by the knowledge where exactly bladder and rectum is. So it is quite sufficient to work on 2D planning. If it's and I think it is better to use these standards treatment than to think it's not a good treatment without CT and avoid that. So better do a treatment with a lowest possible standard dose than thinking it's not suitable anymore. I think it's getting more difficult from this old-fashioned way of reconstruction when you come to needles which are implanted. Here you see an implant for cervix, which is combining an intrauterine applicator and needles. So I know that in the past people learned by how to reconstruct this by these just two 2D images, which are perpendicular orientated. But of course, it is much easier, and I think safer to do this in 3D. So if possible, try to use the 3D or a scan. So although it is not that difficult to do the reconstruction on these two images, when you come to this case of vulvar carcinoma recurrence, yeah, I would say this is almost impossible to do this by two 2D images, and it's very helpful to have a CT scanner here. And you see, I can manage my images to be or to see the catheters in one plane. I can turn the images until I'm in plane. But what is very important too, I have some pictures, or I get from our team some pictures where the buttons with the numbered buttons are to find. And so I can place some points, some marking points on top where the buttons are on the skin with the numbers, and then I know where my catheters come out. So this is to mark catheter number 20 or catheter number 19 here. And then I can try to orient my image so that catheter number 19 comes clearly inside. Yeah. Oops. And yeah, so I found a paper here, or an image in a paper where there is one problem mentioned. When you want to do superficial modes, you have sometimes the problem of air gaps and wondering, what's going on with this air gap. Good. And so I was working on looked at what I find out on that too. First, it is important to choose the right image quality, or let's say the right slice thickness to work on your image when you want to do some reconstruction later. So you can see how the quality improves just by taking an image set with 1.5 millimeter. So the scan was always the same, but the reconstructor of OCT was changed in the slice thickness of the final CT data set. So we see here the differences. Now you see still there must be the way of the catheter. Here it's quite clear. But when things happen that you have an implanted catheter and it's just in between, right in the middle of these 2 millimeters, or even sometimes with 3 millimeters, it happens, it can completely disappear. And so it's getting very difficult to reconstruct this properly. So whenever you have catheters which are in the same plane like your slice, take care that you have very thin slice thickness in your imaging. It is absolutely different when your catheter is going perpendicular to your data set. So you have very clear images and you can clearly find your catheter. Another point is when you want to say something about how well your mold is fitting on the skin, you must be very careful when you use fiber flap as well. It depends where you are in your slice or in your data set. So this is the transversal view, and this is a coronal view. And when you take a look on the coronal view, you would think it's not very close to the skin, but it is due to this, you are right here, and there is a distance between, because we have these pearls. Yeah. And sometimes you have some problems, and this can happen with patients too, that you do not, or your flap is not properly fixed to the body of the patient, or you cannot manage to press it down here. Another point which is very important when you try to, before you start imaging, take care that you take out what is not needed inside for imaging, like mandrels. So for the flap, it's very nice to have air in it. But for a plastic catheter in the body of the patient, we prefer to have some markers in. So take care that for imaging, the markers are inserted properly. Yeah. What else you could keep in mind is, as I already mentioned, a small flap can be calculated on a phantom too. It's not always necessary to do a CT scan or an X-ray imaging, because the information you get out of it might not be more helpful for the patient himself. So you can do it on a phantom, and but if it's banded strongly, you need some data set for the correct bending and optimizing on that special bending condition. Okay, so the imaging is followed by planning, and I think this is will be explained in depth by the presentation of Dr. Swamidas tomorrow. And then there is a plan QA. Well, I hope it will be part of the presentation of Dr. Hack. I think he's talking next Friday. So when you are happy with your plan, you start loading and checking treatment documentation. But however, I would like to talk a little bit about the plausibility check. So we do this, and so, okay. Obviously, I have forgotten to translate that. Sorry. Oh, I must apologize. It was not exact. Yeah. I hope that you have got that. That you have got this in English already. Maybe I mixed up there something. Otherwise, I will check if you're, because I did a translation of this today. Okay, so there are in some textbooks suggestions how to check the quality of your plan. And these checks are influenced by the ideas of your medical doctor, how he wants to have his dose distribution, and how he is in contouring, or how properly he makes his the contouring. But you have to keep in mind, very often the medical doctors work under pressure because the patient is under anesthesia. So sometimes, or more often, however, contouring and brachytherapy is not that properly made like you are used to know it, to see it from for EBRT. And so to be independent from that, what my doctor, my medical doctor is doing on that, but I want to have a rough idea if the treatment time, or the sum of dwell times, and my prescribed dose and my dose volume are in a plausible relationship. So this is a short test which works quite quick, and I have reference, or I have a reference taken out of this Krieger phantom measurement. I do not know how many of you have dwell time measurement for calibrating the source, or if anybody still uses a Krieger phantom. This is a phantom supplied by PTW here from Germany, and was very widespread a couple of years ago. And so you can measure your source in PMMA phantom, which is cylindrical, and you have 4 measuring points which are in 8 centimeter distance to your source position. As you see this, and you get some information, I just use here the activity and not the reference air camera rate. Of course, you can exchange this into reference air camera rate. I have my reference distance and I have my reference measurement time, which is 90. It was recommended to do a 90 seconds measurement. And I have my dose that I got out of that. So this is a certain, these are my reference conditions, and I try to calculate a reference or an equivalent time. So by comparing my prescribed dose to the reference dose, my equivalent radius, this is just the radius when I assume that my isodose volume is a sphere, to my reference radius, and my my reference activity to my my actual activity and times the reference time. So so this is my equivalent time, and so my index is made of, I compare now the time out of my planning system to this equivalent time I got out of this formula. So, and I took I collected a good part of data set, over 100, and from this I exerted some or defined some rough limits. So it looks like this. Just it is just one line. I know where what the diagnosis is, something like vaginal case. Yeah, you see here there are even almost equal sizes of the isodose volume, but we had here different prescribed doses because there have been different situations a little bit. This is the activity of the day, and usually we get a number, it's around that. And it works for arbitrary volumes I take out of clinical daylight. Yeah. So just a short test, but it is not saying something of your plan quality. It is just to check the plausibility if your system is calculating correctly the dose. Yeah. So so when you are happy with your plan and you send it to the treatment machine, or you create a treatment file which is picked up by the treatment console, you have to compare it. And we go through, or usually I do this together with an RTT, which is working on that day there. So we compare the reference dose, so which is written the prescription dose. We compare the actual dose for today here, and yeah, and we compare it. Okay, yeah, we compare the factor for the indexer length like that, and the total treatment time, which is shown here, and we compare. Oh, sorry, I was taking too short. Sorry. We compare the time. Usually, we say we think it's enough when I checked all the other times and so on. Just the first, last, maybe in the middle. But we do this for every catheter. So what else we do is I check together with the RTT for correct reconstruction and check for correct connection. We take photos for documentation, and we put this documentation into our record and verify system. So we use Mosaic from Elector, but unfortunately there is not a good direct connection between the treatment console from the Brachy system to the Mosaic. But we do, we have all our Brachy patients in the Mosaic system, and we add all the documentation, all the photos, we add all the plans, treatment reports, and we check also the, and we put in a field, like for, you know it from the EBRT, but it is manually treated then. Okay, good. I see the time is running. One point I would like to mention, you have now seen that we have some interesting treatments done in the past, and especially if you see molds and something like this, or combinations of molds, maybe you think of how reproducible it is, or is it very uncertain what you do then. We had one very special case, which was very difficult to treat. This is a basalium case where it was just, it didn't stop to grow. And this patient was treated first here in the head area. He had a basalium in his face. And so he lost his eye. But it was growing after this treatment for 4 more years. And then he got a brachytherapy. Maybe you can see, while here we have still some bone under our catheters, there is the bone missing. So here inside there is no cancer anymore, but no basalium anymore, but the basalium was growing then here. So there was only a little rest of the nose left. Of course, we have some nice colorful photos of this, but I do not want to go that this goes viral, so I don't show that original photos. And you see, this is a part of the in the back of the nose. Here you see one eye. Here is no eye anymore, and yeah, you can imagine something is missing there from his face. Yeah. So we compare. You see, it is very difficult to place anything else there, and it's a big, good question. How can you treat this? And so our doctor decided to use brachytherapy, and he had to place every day himself these catheters there and fix it up somehow. And it was, in this case, not done by our RTTs, but by the medical doctor. And we took CTs from scans from after he placed this for the next friction. And so we compared, and we didn't do every time a new plan because it needs too much time. However, I add some contour here because our medical doctor is usually treating on the just on the surface, but for doing a comparison, I needed a contour here, and took a look on that. So we planned this, and this was our fraction. So we had some deviations, in volume and in dose. I used here the deviation in absolute dose values. You see, the dose values per fraction are not that big. So in percentage or relative, it might be big, but for the medical doctors, it is always a question: what is the absolute dose deviation in volume? For some, so for bulbous and for lens and so on. And HC is, I think, my helping contour for the skin, which was not given by the medical doctor. So therefore HC for helping contour. It's my creation of CTV. It's not a real CTV. It's not given by. Yeah. So you see here that we have some deviation, that these 100% dose volume was 17% smaller for the next fraction. Yeah, but okay, the volume itself was very small. And on the other hand side, the big question is, how well can you treat such difficult situation, or how certain can you do repeat this treatment when you do an EBRT plan? So yeah, that's it for today. Thanks to this is my Brachy team, and thanks to them too. And thank you for your attention.
Thank you very much, ma'am, for your excellent and informative talk. And thanks to all participants for your interest in this program. There are some questions from the participants. So first question is from the Deepak Kumar Jaha. How do you ensure reproducibility while using flap for skin treatment? And we face a lot of air gap issue while putting flap. What do you suggest to manage this?
Sorry, I didn't understand completely the second part of the question. For the first, I have already the answer.
Yes, ma'am. I again repeat. We face air gap issue while putting flap. So what
Okay.
do you suggest to manage this?
Okay, so one point is how to the reproducibility of flaps. Okay, you see, let's go back there. Good. So what you do not see now, because there's a plus there, but there are always markings by our RTT done to place it right here. For a small one, or when you take a look here, this is for this great one, there's a marking. So it depends a little bit on the sort of type of cancerous disease. So depending on the cell type, they have sometimes a large additional area to be treated. So, and for some others, it is just a small safety rim around, or say you add some for safety. However, I think it is quite I know that many colleagues think this is not very reproducible to do this, but honestly, it is not worse than treating something like that on a Linac. Yeah, you are not that good reproducible on a Linac too. This is one point. I think, yeah, well, you should add some area to have your real clinical tumor area good covered, so that it doesn't matter if you are 3 millimeter here or 5 millimeter there. Yeah. So, and you can take place in you can take care in your planning that your plans are stable. So I do not like it when they say, okay, we need some more dose in this area, so let us create their hotspot. Yeah, so we try to have a very smooth and harmonized dose distribution. So when you, so here you have higher dwell times, and here you have quite they are lower than at the outer dwell positions, of course, but you can move it a little bit to this part and to that part, but it doesn't change so strongly. For small lesions, I really go through my plan. I do not, sorry, I have not these examples here to show you. It would need some time to find them. But it is possible. Imagine you have 5 by 5 catheters by 5 pearls, so approximately 5 times 5 centimeters, something like that. And you can arrange it that you have an equal or symmetrical distribution. So even when the RTT, she was too busy and somehow exhausted, and now she just places it in another direction. So I myself, I always try to, if it's whenever it is possible, I look for a symmetrical dose dwell time distribution, because I'm quite sure in that case it doesn't matter if you are moving to left 5 millimeters, or 5 millimeters is quite a lot then, I think, but 3 millimeters may happen, and it's no problem then. Yeah. And for this combination with for the combination with the interstitial needles, I say, okay, what we can only do in that case is all dwell position in the flap we can plan with our planning system only with equal dwell times for all positions. So it doesn't matter so much if you just move it a little bit. Yeah,
Okay.
and the air gap in between. So we found out it is not that much because we are usually within 5 millimeter distance between skin and our source. So the air gap is not that dominant. So in the calculation, even when you do it with 186.
Okay, thank you, ma'am. And second question is from Subhas Haldar. How do we recognize tip of catheter in MRI image if catheter is not MRI compatible?
Sorry, please repeat the beginning of the question.
Yes, ma'am. Yes. How do we recognize tip of catheter in MRI image if catheter is not MRI compatible?
Oh, yeah. Well, I have to admit, we do only use MRI with these spring applicators or this special applicator. So I must honestly say, I don't know what you do then. Yeah. So we have special MRI compatible catheters or applicators, and but usually, so we do this. Our doctor implant the intraurinary or cervix applicator in which are in our house MRI compatible, and then he goes back to CT scanner, add some needles, and do finally a CT scan. So I'm sorry, I cannot answer.
No problem. Thank you, ma'am. And third question is, what are the major advantages of using brachytherapy for breast cancer and cervical carcinoma? Major advantage.
Yeah, major advantage. Okay, in our department, we don't do this primary breast cancer treatment, but recurrences, or in rare cases, we do primary when the solid tumor is too big, so that the surgeon say, please do first something to reduce the size of this tumor. So in this case, there is a certain advantage because you can put on this this tumor which is still inside or in the breast. You can add a very high dose just to melt down the tumor. Yeah. And for cervix, there are already ongoing studies or well-known studies. So I want to, so try to find out what the Embrace study is has published already. I think it's set up from the European from the Astro or from the Jack Astro, but I know that even Tata Memorial Hospital is taking part in this study. And so studies like the Embrace study have shown that the overall survival of cervix patients receiving an additional brachytherapy have a better chance to survive than without, because you can add a very high dose to the high risk volume of the cervix carcinoma without giving too much dose onto bladder or rectum wall, because you have a high dose around the needles, which is very helpful in that case.
And last question is, why use brachytherapy for treatment is still limited?
In that sense, limited, that is not that widespread like EBRT.
Yes, means brachytherapy treatment is still limited, not means much.
Yeah, not so. I don't know. I wish it would be more spread out and more used. In my opinion, when you have a modern linear accelerator, what you can and a modern planning system, and combine it with a brachytherapy, there is almost no need for proton therapy anymore, and you are much cheaper with your department. So, and I'm wondering too.
Thank you very much, ma'am, for sharing your knowledge and giving your valuable time to us. It is a wonderful opportunity to be associated in contributing towards the e-learning program conducting by SCM-PCR under the guidance of Professor Ghulam Abu Zakaria sir and Professor Dr. Asin Anupama Hajari ma'am. I would like to thank to Chairman of SCM-PCR, Professor Dr. Ghulam Abu Zakaria sir and Professor Dr. Asin Anupama Hajari ma'am to giving this opportunity to me. And thank you very much all participants once again. We appreciate your presence here. Our next lecture is on tomorrow. Topic is brachytherapy treatment planning. So we will see you tomorrow. Thank you everyone.
Thank you from my side too. Good afternoon.